Hi everyone, I'm here today to talk about CT scans. So a CT scan stands for computed tomography, which you can see at the top of the screen. Tomography itself is just a technique that we use for displaying a representation of like a cross section, which is like an axial slice through the human body. Throughout the slides, I'm going to refer to a slice quite frequently when I'm referring to an image, and I'll kind of get into that a little bit more as we go along. So simply put, tomography is just imaging by sections. When we think about CT, a lot of times I use the reference of a loaf of bread. So take that loaf of bread and stand it on the end, or what my kids like to call the butt pieces. So you got a butt on top and a butt on the bottom, and all the slices of bread are in between. So when we talk about CT and how they scan, what the amazing thing about CT is the machine is taking those slices of an image, and they usually depends on the machine, but they're about 0.5 millimeters to like 1.5 millimeter slices. So if you like take a piece of that bread out and look at it individually, you can look at it from the top or the bottom, and you can see if something is inside of that loaf of bread in each individual slice. So we wouldn't miss something that's really small. So you can put that slice back in and then pull another slice out and look at that more in depth and put that one in, and so on and so forth. So a CT scan is essentially looking at like a loaf of bread, but using the body instead and being able to view each one of those slices individually to look at the anatomy and see if something is going on. Some people also refer to CT as a CAT scan, CAT, so that stands for Computed Axial Tomography, because we use the computers. Axial is the plane we slice in, and then again, tomography is imaging by sections or seeing a slice. Axial is the most common scan plane used in CT. CT can scan in axial, sagittal, and coronal planes, but axial is the most common plane used in CT. So again, like I said, CT scanning is just a series of X-ray images. It uses X-ray technology taken from different angles around our body. And then it's using that computer technology to create or reconstruct those images into cross-sectional images or slices of the anatomy. So CT is very fast, it's very patient-friendly, and it has the unique ability to image a combination of our bone, our soft tissue, and our blood vessels, which isn't something that a lot of modalities have. We usually use X-ray to look at our bone, we use ultrasound to look at the soft tissues, and then we use angiography to look at the blood vessels. So the great thing about CT is it kind of combines all of those things into one imaging modality. CTs are going to give a lot more detailed information than a plain film X-ray would, but the big trade-off with that is CT scans use a lot more radiation than regular X-ray, and the cost is a lot higher. So those are things that we have to weigh out when we're doing imaging. Well, the doctor does. They've got to weigh these different things to determine what would be the best test for the patient. Just to give you a little example of what I mean by the different doses. So a regular chest X-ray is about 0.1 millisieverts of dose. That's how much radiation we're getting from that. The millisievert is how they measure it. It's their unit of measure. So a chest X-ray is 0.1 millisieverts of radiation, which is equal to about 10 days of natural background radiation that we get. I don't know if you remember from the radiology chapter, but I said we get background radiation from a lot of different things. The granite countertops, radon from our basements, in our home, the sun, flying on an airplane. So a regular chest X-ray is about equal to 10 days of natural background radiation. It's, again, 0.1 millisieverts. A chest CT is 7 millisieverts. and it's equal to 2 years of natural background radiation. So if that kind of gives you a little idea of how much more radiation it is, we just really want to make sure that the benefit is outweighing that risk. There's a lot of amazing benefits that come with CT, and it's a wonderful modality that we use quite frequently in diagnostic imaging. So, sorry, I'm getting it to turn. So this is a literal CAT scan. A lot of veterinary hospitals have CT and MRI scanners that are capable of scanning large animals, such as this lion. And honestly, on occasion, all x-ray tables and CT and MRI tables, they have weight limits. And also, if you look here at the opening here, which is the aperture is what we call it, they're only a certain size. So in hospitals, we may occasionally have patients who are either too large to fit through the opening, or their weight limit exceeds what our table will allow, so we can't scan them at the hospital. Unfortunately, in those situations, what we do is we refer them to a veterinary hospital like MSU, and they'll use those scanners to scan patients that won't fit in the scanners at the hospital. So CT, or computed tomography, was developed in the early 1970s, 1972 to be exact. So in 1972, Dr. Godfrey Hounsfield, he was from England, he invented CT. I would remember the name and the year if I were you. So Godfrey Hounsfield was awarded the Nobel Peace Prize, and he was also honored with knighthood. He was knighted in England for his contribution to medicine and science, which is pretty amazing. So CT was a huge, major advancement in diagnostic imaging. This was the first time that doctors could obtain cross-sectional images or slices of anatomy. It really helped open up the world to diagnose a wider array of illnesses and injuries than were ever possible before. This was huge. This was one of the original CT scanners, so this is called a CyreTom. It was a dedicated head CT scanner. This was made in about 1974, so as you can see here, if you remember the opening around the cat or in the original image, that was a lot bigger. The whole body could fit in it. This one is very small, so this patient's head is only able to fit in there. So remember, it could not scan the entire body. A CyreTom scanner was a dedicated head CT scanner in the early 1970s. Whole body scanners that came with larger openings didn't become available until about 1976, so it was a couple years later. Can anybody guess how long the original CT scans took? So they were actually around 8 hours for just a simple brain scan, a head CT, on that CyreTom scanner, which could only scan heads, remember? It actually took several hours for a single scan or a slice, and on top of that, it took days after the scan to reconstruct all that data into a single image. So that was a huge length of time. So in the early days, CT was not meant for trauma or fast situations. It took a very long time. And the problem with that was that patients needed to lie still for those images. Anytime a patient moves during a CT scan, it can cause blurring. So imagine trying to lay still as a patient for 8 hours, depending on the scan. So this was like very early on, but doctors were still amazed at what they could see. In the early days, like I said, it was not good for trauma due to how long it would take. But today, we use CT as a valuable tool for strokes and trauma, which are something that require very fast diagnosis so we can know what's going on and start to determine the route of treatment for these patients. So after a while, they started inventing faster scanners, which was less motion artifact, more patient-friendly. Obviously, the patients weren't having to lay as still as long. And they were getting better quality images with less dose, because if they can scan faster, that's less radiation for the patient, right? So multi-slice scanners they can collect data up, those earlier ones, could collect up to 4 slices of data in about 350 milliseconds. And then they could reconstruct the data in less than 1 second. So there was huge improvements in the speed. You know, going back to 8 hours originally, now we're at about 1 second for reconstructing data instead of a whole day. So going through now, an entire chest CT can be scanned in 5 to 10 seconds. And scanners are even better than that, 4 slices of data in about 350 milliseconds. They now have, most common scanners are about 64 slices. And they have up to about 320 slice scanners. So a 64 slice scanner is a high resolution scanner. You get 64 slices per rotation of the CT scanner. The 64 slice scanner is about as thick as a credit card. So each slice, each scan of the patient is going to be about the thickness of a credit card. So imagine that. When we're looking at these images, when we're looking at, say, the chest and we're looking for lung cancer, you know, it can start very small. And on a regular x-ray, we might miss that. So if we can take those slices and each slice is only as thick as a credit card, that means we can find very small cancers very early so that we can help treat those patients sooner before those symptoms become big and they you know, stage later where it might not be as easy to cure. So just for price reference, a 64 slice scanner costs about $1 million. And a 320 slice scanner is about $2.5 million. So they're pretty expensive when you think about it like that. All right, so these are 2 different scans. This one here on the left is the original Tom scanner. Remember, the one that could only scan heads. So if you look at this image, it's very pixelated. It almost looks like an old video game. This one was about 128 by 128 matrix. So it wasn't great quality, especially when you look at the one on the right that's more current of an image, that you get about a 512 by 512 matrix. You can clearly see the difference in these images. This one you can see the ventricles right here, which is very good. I mean, doctors were amazed at this time. Back in 1975, they were amazed to be able to see the soft tissue structures of the brain and these black ventricles here for the very first time. They weren't able to see them originally before this, so this was huge. These ventricles are actually enlarged on this patient. But you can't see the soft tissue. All you can see are pixels. You can't really see the clear definition of the skull and the scalp. I mean, on this one, look at the white line here is the scalp. And then the thicker white here is the skull. And then we've got all the brain tissue here. And you can start to see the ventricles here. Much more detail. But still, this was amazing for its time, and doctors were thrilled to have it. So the CT scanners, they actually use multiple computers to be able to control the entire system. So what they have here, so this is usually behind a lead wall. This is not in the same room. It's just kind of showing it together on one picture. But the CT technologist who's scanning is separated because this is radiation. It's emitting radiation. So we don't want to be in the room when the patient's being scanned. But there's a gantry, which is this donut-shaped thing here, with the aperture, which is the hole that the patient will go through. This is the table that the patient lays on. This table has the ability to raise and lower, and then move in and out of the scanner. The gantry itself can actually tilt. It's hard to tell here, but it can tilt so that we can angle and view the patient at different angles. There's a main computer, a workstation, and a control console. So the main computer can control the operation of the entire system. There's also a dedicated computer that can reconstruct the raw data into an image. And then there's a workstation that usually has a mouse and a keyboard that allows the technologist to control and monitor the exam. So picking the correct patient, the exam that we're doing, setting everything up. And like I said before, so this CT gantry can control the table and the angling itself. So there's buttons on there, and all of them are different. A lot of them are actually on the side, so it's easier for the technologist to control, and it has it on both sides. So no matter which side you're standing on, you can control the machine. How does CT work? Well, CT is based on the X-ray principle, right? So we're using X-ray technology. It is radiation, and we're passing those X-rays through the body, and they get absorbed or attenuated, just like regular X-rays. And then in normal X-ray, that's registered on a film or an image receiver, right? But in CT, that film or image receiver is actually replaced with a different kind of detector. It's more like a banana-shaped. I know that sounds kind of weird, but I'll show you a picture of it in just a little bit. So the CT scanner is like a big donut, like I showed you on the image before. The opening or hole inside is called that patient aperture. It's usually about 60 to 70 centimeters in diameter, which isn't really that big. So like I said, if you've got a patient who's very large, has a very large belly, they might not fit through the scanner. If you actually took that scanner cover off, and I'll show you in just a few minutes here in a future scan, inside is a rotating frame, which has an X-ray tube mounted on one side, and then that banana-shaped detector mounted on the opposite side. And they rotate in unison together around the patient. When the X-ray is turned on, there's a fan beam that kind of comes out of that tube, and then it hits the detector as it's rotating 360 degrees around the patient. And then, like I said, each time that tube or detector makes a 360-degree rotation, an image or a slice is acquired. And it's going to depend on the type of scanner you have, but you could have a 4 slice, a 16 slice, a 62, or 64, or a 320 slice. And you're going to get that many slices each time it goes around the patient 360 degrees. So then after all of those slices are obtained, everything's kind of reconstructed by the computer into a two-dimensional image of that slice that was scanned. After the original scanners were made, they came out with something called a spiral helical scanner. This was the advancement that the medical community was waiting for. Remember before, when it was like 8-hour scans, the CTs can be done in less than a second. And it was a continuous motion. So the early scanners, what would happen was you'd have that tube and the detector, and they would scan, and then they would go all the way around the patient one time, and then they would stop, and then they would have to scan back the other way, and then stop, and then reverse each time. Well, with this new spiral helical scanner, what they could do is continuously go 360 degrees and not have to reverse. So it was a constant flow, which was able to help it increase the speed of the scanning. Sometimes we have the patient hold their breath during the exam, and the machine tells them when to do that. So when we start the scan, the machine actually says in this really techie computer voice, hold your breath, and then it's, you can breathe. So you don't actually have to tell the patient, the machine is going to do that whole thing all by itself. It actually takes longer to pull the patient's name up on your computer, get them positioned on the table, and do all that than it does to scan them. So this is what I was talking about when I was referring to some of the inside of the scanner. So this is what one of the outside of the scanners looks like, no big deal. If you take that cover off, in here you've got the tube, and here's that kind of banana-shaped curved detector. So the tube is at 1 o'clock, the detector's at about 7 o'clock. What happens is this whole thing is going to start moving when you turn it on, and it scans. But the tube and the detector always stay at these opposite positions, so that the x-rays are coming out of here through the patient that's in this aperture, and then they're taken up or attenuated by this detector here, and that's how the image is taken. So as this moves all the way around the patient, it's taking continuous slices, 64 to be exact, by the time the tube reaches back to that same position. What I was saying, in the early scanners, what would happen is the tube would move all the way around, and it would stop, and then it would have to return back the opposite way, stop, and then scan again. And it would do that, and that's why it took a little bit longer. Now, the tubes can continuously go in 365 degrees rotations all around the patient. There's actually a video on this next slide. If you want to click on this hyperlink, you can, and it will show you a video of how the CT machine scans. They take the cover off, and you can see it rotating around the patient and how it really would. So again, here's that detector. This one kind of gives you a little idea of the patient on the table and the x-ray tube and the beam coming out. So you can see this green beam is coming out. And it would do that continuously as it rotates around the patient. Just another indication of what it would look like. So the banana detector inside the tube, there is a collimator inside there, but you can see here how it's kind of taking that one little slice of the patient. These are two different modern CT scanners here. So you have the patient lie on the table. This gentleman over here is using the controls to raise and lower the table, bring the patient into the gantry. There's laser lines, you can kind of see one out here and on the patient here, that help to determine where you want to position the patient. This one here that this lady has, this is what we call a power injector. So we do use contrast. We'll talk about that a little bit later. If we're using IV contrast, we don't want to be in the room when we're injecting the contrast because then we're subjected to the radiation. But we need to give the contrast at an adequate time so that we can still take the image and visualize it. If we went into the room, injected the contrast, walked out and started scanning, the contrast would already be out of the area of interest. So what we have here are these power injectors. So the patient would have an IV, we'd hook them up to this, and then we can control this back behind the console. So we can determine when that patient gets the contrast and how much they get without ever stepping foot into the room with the radiation. This is a CT scanner at a children's hospital. They've just have the whole room painted to look like a pirate ship. I thought it was pretty cool. You know, it kind of helps the kids alleviate a little bit of that fear that they may have. So that's a scary time for patients of that age, you know. I mean, most patients can get nervous, but especially children, it can really make them nervous. So anything we can do to help ease their fears is good. Another veterinary scanner. So obviously you can see here this opening is much bigger and this table is going to be able to hold a lot more weight. So that's why we would send a patient to a veterinary hospital if they weren't able to fit through our scanners. The pertinence to the medical community for CT is huge. I mean, the invention of CT transformed our whole field of medicine. It gave us a new glimpse into the body where standard x-rays just couldn't. So CT is very quick, and it has the ability to image a combo of our bones, soft tissue, and blood vessels. And I said that before. I mean, x-ray is good at looking at the bone, ultrasound's good at looking at soft tissue, and angiography is good at looking at the blood vessels. But this finally combined everything together so that we were able to see that. CT is actually one of the best imaging tools for studying the lungs and the abdomen. And CT is invaluable in the diagnosis of cancer, strokes, and heart disease. There was actually a study done in ER departments that showed after a CT scan of the chest was done, the treating doctor, their diagnosis changed 42% of the time. So what they thought was the diagnosis originally prior to the scan, after they were able to see the imaging, they changed their diagnosis 42% of the time. That's huge. What that's saying is CT is able to truly diagnose something that maybe the ER doctor was guesstimating. And in abdomen CTs, the diagnosis changed 51% of the time. This is a testament to what a huge impact CT technology has in sparing the patients from improper diagnosis or unnecessary surgeries. And it also is huge with getting urgent treatment faster. I mean, one of the biggest things with strokes is we need to act fast. We need to know what's going on fast and diagnose it so that we can help treat this patient and eliminate some of the permanent damage. So CT is instrumental in getting that quick diagnosis for a stroke. CT can provide evaluation of nearly every part of our body. Bony structure, the brain, blood vessels, our eyes, our sinuses, and our inner ear. There's a lot of bones inside of the inner ear, and they're very small and tiny, and it's hard to see. But with CT, it can go through those slices, and you're much better able to visualize it. It's good at evaluating the chest, lungs, heart, and aorta, abdomen, liver, kidney, spleen, pancreas, and gallbladder, so all of the abdominal organs. It's also great at looking at pelvis and hips for fractures or injuries, reproductive organs, and the bladder. And it's good at looking at the GI tract. So essentially, CT is really good at looking at everything. The most frequent exams for CT are head, chest, and abdomen, pelvis. So abdomen, pelvis are usually combined a lot of times. So there's differences, obviously, but chest, head, and abdomen are the three most common, but abdomen and pelvis are usually combined together. So the number one most common is the head CT. Head CT examinations are of the brain and surrounding tissues. So some of the symptoms for patients who might need a head CT could be severe headache, neurological changes, slurred speech, dizziness, or paralysis, sometimes numbness, loss of consciousness, or trauma. So if somebody asked you what scan we would do if the patient had left-sided paralysis, that would be a reason for a head CT. The number 2 scan is an abdominal CT. That has been considered the golden standard for evaluating the abdominal cavity for any pathology that we're looking for. So the primary reason for this is that CT can identify and differentiate between most of our soft tissue organs. But it is difficult for CT to differ between bowel and gynecological tissues. There's not a lot of visual differences in them, so it's kind of hard for them to see that. That's a good thing to remember, that it's difficult for CT to differentiate between bowel and gynecological tissues. The abdomen CT usually evaluates from the diaphragm all the way down through the pelvis. That's why we call them a lot of times abdominal pelvis CTs, because it's one and the same. Common symptoms for a patient to have an abdominal CT are pain, abdominal pain. If we're checking the liver, it can be renal, pancreatic, or bowel cancer could be the reason. But one of the main reasons, so if somebody said, you know, what would we scan for a liver mass? Then your answer would be an abdominal CT, right? Because the liver is in the abdomen. So to look at liver masses, we would do an abdominal CT. The third most common CT exam is a chest CT. They're used to evaluate suspicious areas identified on a chest x-ray. A lot of times, the patient will have a chest x-ray first. If they see something, if the radiologist says, oh, I don't know what this little spot is here, let's do a follow-up chest CT so we can look at that a little bit better. That's very common. They're also done for lung cancer screenings. So if somebody has a history of smoking, they might do that ahead of time to try to catch the lung cancer early. Common symptoms for a chest CT would be cough, wheezing, chest pain, or shortness of breath. So if you were asked, you know, what would be a reason for a chest CT, wheezing and shortness of breath could be the reason. We do use contrast material in computed tomography or CT. So CT contrast is used to make specific organs or blood vessels and or tissue. It helps it stand out. So with more image contrast, it helps better show the presence of disease or injury. It's really important to use contrast material in certain studies for CT. So again, like I said, CT contrast will highlight specific areas of the CT image, or it dyes it. So we sometimes refer to it as X-ray dye or contrast dye or CT dye because it's actually dyeing the image where we need to see it. Contrast can be used orally So that means the patient's going to drink it. It can be given intravenously, which is an injection through the vein, or it can be administered rectally, which is contrast in the rectum, just like a BE study would do. So again, it's our job to watch for reactions to the patient and also to inform them of what common reactions are, normal reactions. So remember, just like I talked about in fluoroscopy, anytime we give contrast through the IV or intravenously, the patient can have a warm flushed feeling, they can have a metallic taste in their mouth, and they can feel like they wet their pants. Now, it's even more prominent in CT because we use those power injectors, which means it's injecting it at a faster rate. So the reactions are going to be a little bit more intense. So it is vital that you inform your patient that those are some of the side effects, just so they don't freak out or get nervous. So again, and I said this before, it's important to tell them what the normal side effects are so that they know if there's anything abnormal going on. Some of the more serious ones could be difficulty breathing, hives, swelling in the throat. And again, they can have such a bad reaction that they can go into anaphylactic shock and it can cause death. So we need to make sure that we are really paying attention to our patients and checking with them. Preparation for a head CT. So anytime you're given a contrast injection, you should not have anything to eat or drink at least 3 to 6 hours prior to the injection because it can cause an upset stomach. If we have food or drink in our stomach and it becomes upset, it could make us vomit a lot easier. So that's a lot of the reason why they want a possible 3 to 6 hour NPO prep, nothing per mouth, no food or drinks, before they give any contrast, especially IV contrast. Now, that's not going to be a determining factor. Obviously, if we have trauma situations and we have to give the patient contrast, we're going to give it to them whether they've been NPO or not. We're not going to make them wait 3 to 6 hours if it's an emergency situation. We're just going to go ahead and give them the contrast and scan it because the benefit outweighs the risk. Okay, worst case scenario, the patient might puke, but if they just were in a car accident or we're worried that they just might have had a stroke, them puking is not that big of a deal in the grand scheme of things, right? We want to hurry up and get that scan done. The patient perspective for a head CT is it's pretty easy, especially if it's non-contrast. We do non-contrast head CTs and with contrast. It's going to depend on what the doctor's looking for. So if they don't have to have contrast, then it's really easy. They're so quick. You don't have to do much. You can take off your glasses, maybe your necklace, earrings, things like that. If you have to have an IV, then it can be painful. Some people are really scared of needles. It can cause anxiety. And again, you get those weird warm flush feeling, metallic taste, or feeling like you wet your pants. Up until it could be deadly. If there is a serious contrast reaction, it could be deadly. Now, obviously, that is worst case scenario. It doesn't usually happen, but it is something that's, a possibility. A head CT for technologist perspective is they're pretty routine. They actually do a lot of them throughout the day, so pretty normal. They can be exciting or scary due to emergency situations. It wasn't too long ago where I've seen one of the worst brain tumors I have ever seen on a patient before on a head CT. I've never seen anything like it. So this was a younger patient, and I don't remember how old they were, early 40s, late 40s. But that's heartbreaking. You know that this patient is going to find out very soon that they have a large brain tumor. So, sometimes seeing things like that for us is neat because you've never seen anything like it, but it's also heartbreaking and you feel for that patient because you know what they're going to be going through soon. Anytime you're starting an IV and dealing with patients, again, it could be risky. We're being exposed to diseases, especially, like I said, if you're starting that IV, you have the risk of being exposed to AIDS, HIV, hepatitis, things like that. Again, side effects are going to be the same normal side effects that we talked about. The patient could have nausea and vomiting as well, like I said, especially if they've eaten in those 3 to 6 hours. Other contrast reactions, the patient could have tachycardia, which is what? A rapid heart rate. Hypertension, which is high blood pressure. Syncope, it's dizziness. Myocardial infarction is a heart attack. Kidney failure, anytime we're giving a patient contrast, we could put them into renal failure. Contrast is hard to process through the kidneys, so if a patient already has kidney issues, it can cause kidney failure. And worst case scenario, very rare, very, 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 very rare is death. The cost of a head CT is approximately $1,500, give or take. So that's expensive. Remember when I was talking about x-rays were relatively cheap? This is why, because CTs are expensive and MRIs are even more expensive. This even might be on the low end of things if I were to research it. Today's price, it might be even higher than that. So when we're reading a CT scan, it's a little bit different. We're still looking at the patient like they're in anatomical position. So the patient's right is on our left side, their left is on our right side. But we're also looking at the image like we're looking up at the patient from their feet, if that makes sense. So we're looking up at them from the bottom. So because it's a slice instead of just one image, that's why it's weird like that. Contrast, just like x-ray, is going to appear white on the image. Blood is going to be a gray to white color. Bone is white. Tissues and fluid are going to be various shades of gray. So like cerebral spinal fluid, blood, things like that are going to be various shades of gray. Air and fat are going to be black. So again, just like x-ray, air is black. So when we're looking at a lung scan, you're going to see a lot of black from that air inside of there. So this is what a kind of like a scout image would look like. So the CT scan does a quick scout image, and then what you're going to do is you're going to place your slices. So these all kind of represent a slice of the anatomy. So you can see here, this anatomy is going to end up on this image, this anatomy through here is going to end up on this slice, this anatomy on this slice, and so on and so forth. And you can see through here the slices get a little bit closer together because as we're going through some of the sinuses and the bones inside of the ear, there are a lot of smaller bones, so we're going to thin those down just a little bit. This is the different planes that we scan in. So this is the head. So you've got the axial plane, which is going to show some of... Okay, so the axial plane. So it's like you're looking up at the patient from the base of their skull up to the top. So here you can see their eyes, nose, you know, here's part of the brain as it's starting to come through from the bottom. Then you have your coronal plane here. So from the anterior to the posterior side, this is more of the posterior portion, so you can kind of see the brain stem down here. And then you have your sagittal plane, which is the side view, right? So any plane that divides the body into right or left halves. So the CT machine is capable of scanning in all three of those planes. Just the most common one is the axial plane. This is kind of a layout of all of the different slices. So as you can see here, from the base of the skull, you've got the foramen magnum here, all the way up to the very top of the skull cap, and all of the images and slices in between. So this is another way that we can lay them out to look at the images individually. A lot of times what the radiologists do is they have a whole image and they can scan through it. And there are some of those on JetNet, so you can go through and look at them, and you can actually scroll through the images so that you can see them. This is a normal CT of the brain. So when we look at the brain, one of the first things that we want to look at is, are the ventricles normal sized? So the ventricles in here, are they normal? We want to check the gray versus the white. Is the distinction clear? So if you look through here where the skull is and the gray matter in the brain, are there clear lines? And then one of the other things that we want to determine is the midline straight? So right here, going down the center of the brain, is the midline. One of the most easy to determine factors if there's a growth or something going on with the brain is if the midline shifts. So say there was a tumor growing in here, what would happen is it would put pressure on that midline and it would push it over to the side. It would move that midline over. We call that a midline shift. And that's going to tell us that something is going on inside of there. So we want to check to make sure midline's straight. We want to make sure that the sulci are symmetrical. So these little lines throughout here are the sulci. So they're little furrows, whatever you want to call them, that contain cerebral spinal fluid. So you've got some here. They're symmetrical on these sides, symmetrical here and here. If there's big differences, that could indicate something that's going on. And then we want to also make sure that the skull is intact and that there's no edema or swelling. This is actually an artifact. This is motion. So this is what happens when a patient moves during the scan. So that's why it's vital for them to hold still, because this is non-diagnostic. The radiologist can't see anything going on with this. So we would have to repeat the scan. Another type of artifact is metal. So this patient has metal fillings. Obviously, there's nothing that we can do about that. But if the patient has removable dentures, we would have them take them out. But what happens is there's like this starburst pattern that comes off of the metal filling. So it doesn't give us a good view of what's going on in that anatomy. Usually only happens for a couple slides till you make it through that filling or whatever the other metal is. We can't do anything about that, so we're just going to have to get the best study that we can. These are some different hematomas. So we have an epidural hematoma and a subdural hematoma. The epidural hematomas, they kind of represent like a lens, like if you think of like a contact lens and that curved shape. So epidural hematomas are bleeding outside of the dura mater. A lot of times they're caused by blunt force trauma. So, hitting their head, falling down, something along those lines. A subdural hematoma is a bleed between the dura mater and the arachnoid layers. So this is most common due to tearing or bridging of veins. So the difference is you can always tell by the shape. So you've got the lens shape, and then you've just got the hematoma in here. There's another indication of the difference. So epidural hematomas, they don't cross the suture line right here. So you can see here, it stays outside of that. So you've got blood. This one is caused by the trauma. So you've got a skull fracture here that's causing the bleed. And then you've got the subdural, which crosses the suture line here. And there's venous blood inside of here. This is an axial head CT. This patient has an abscess, a brain abscess, which is potentially life-threatening. So a lot of times it results from like a pathogen, an infection that's growing inside the brain. Remember when I talked about that midline shift here? See how the midline's kind of being pushed over? Because you've got this abscess in here and the fluid around it, it's pushing on that midline. This is a cerebral hemorrhage, so you can see this right here, right throughout there. The cerebral hemorrhage is an emergency situation again. It's when there's a ruptured blood vessel that causes bleeding inside the brain. Most of the time these are caused by either high blood pressure or trauma. Those are the two main causes of the cerebral hemorrhage. These are just images of why it's so important to use contrast. So this one is without contrast over here. You can see the fluid, and then you can see, there's a mass or tumor growth right here. But look at the difference when we use contrast, how much it highlights where the actual growth is. You can see the clear defined borders of it, where here it's a little bit harder to determine. And again, this patient has a brain metastasis. Without contrast, you can see something's going on. You can see the fluid. You can see a little bit of the tumor here. But with contrast, what a difference it is. It highlights it, lights it up, and you can visualize it much better. This is a GSW, which is short for gunshot wound. So you can see here the bullet came in here. There's a fracture in the skull where the bullet came in. You can see the brain fragments. or the bullet fragments, I'm sorry. And you can see the striations or the starburst pattern in this from the metal, right? Because the metal's an artifact, so it's causing that to striate. You can also see some of the blood and fluid around there. And what that also did too is it caused that midline shift, pushed the ventricles way up and is kind of smushing them a little, and then that midline shift is moved over, right? It's not completely straight, dividing it into equal right and left halves. This is an encephalocele. So an encephalocele is a buildup of fluid in cavities. So this sac-like protrusion kind of comes out of the brain. Here, it's a growth. This is what the CT looks like, and this is what it looks like on the infant. This is a 4-year-old that was hit by a car. They have a epidural hematoma. Remember? It looks like that lens shape. This is a head CT with a frontal fracture. So this is the bone window. We can actually change the functions on the CT in post-processing so that we can eliminate the soft tissue to focus more on the bone. So normally we would see the brain in here. We're not really concerned about that, so they're just kind of masking it out so that it can highlight the brain a little bit better. And what you can see here are some fractures. You've got a frontal bone fracture here, here, and here. This is hydrocephalus. So hydrocephalus is a buildup of the fluid in these cavities that are deep within the brain. That extra fluid is going to put pressure on the brain, and it actually can cause brain damage. It's most common in infants and older adults, and the only treatment for it is a shunt. A shunt is actually a tube that's inserted surgically into the ventricle to drain the excess fluid out. It usually goes from your brain all the way down to your abdomen. So moving on to chest CTs. So the prep for a chest CT is NPO for 3 to 6 hours prior. We're going to administer contrast again through an IV. So anytime we're giving IV contrast, we want to make sure that they're NPO for 3 to 6 hours to avoid nausea or the possibility of vomiting. The patient's perspective, again, is usually it's no problem. Some facilities don't even require the patients to get undressed for these. So occasionally they can be uncomfortable, painful. If the patient's having chest pain, they may have difficulty lying still or lying on that hard table. They may also have a problem with the needles. That can be painful again when we start the IV for the injection. And they can have anxiety because they're scared. They're worried. They can have anxiety from worrying about if, they have the possibility of lung cancer, or they might think they have a pulmonary embolism, something going on. So there can be a lot of fear with it. And again, anytime we're giving contrast, there is that possibility that they could have anaphylactic shock and death. So the tech perspective, again, is they're going to be pretty routine exams. There's going to be some emergencies, especially with trauma, MVA, pulmonary embolisms, things like that. Again, anytime we use an IV, start an IV, there is the risk for HIV, AIDS, hepatitis. When we're dealing with the lungs and chest, it could again put us at risk for things like tuberculosis. Side effects are going to be the exact same anytime we administer any contrast. And again, you're going to have the same possible reactions: tachycardia, hypertension, syncope, myocardial infarction, kidney failure, or death. The cost of a chest CT is the same as a head CT, about $1,500. Again, pretty expensive, especially compared to a chest x-ray. So this is that scout image where you can see where they're going to take all of the slices. So it's very important to make sure that you're getting the entire lung field on a chest CT. And these are some of the different views. You've got the axial view from top to bottom, coronal view front to back, and sagittal view from side to side. This is a labeled image of a chest CT. So remember, black is air, So anytime you see an image like this that would be black on both sides, where you wouldn't be able to see many organs, you need to assume that that's a chest x-ray. Again, we're looking at that patient from the feet up, from the bottom up, so it looks like, and then in anatomical position. So this is the right side, and this is the left side. So you can see the ribs out here, you can see the vertebrae here, spinal column, descending aorta, here's the esophagus. The sternum out here, some of the ribs and the chest muscles. I'm not going to go through and talk about everything that's labeled here. Again, another chest CT. Black is all of the air. You can see all the little bronchioles and vessels all throughout here, all these little white things. You've got, again, the spine here. And then another one, another chest CT. So this one you can see more black. You can't see the vessels as much on this one. So this is just straight air. Make sure you know when you're looking at a chest image, in case you're asked what a chest CT looks like, you would be able to differentiate between the abdomens that I'll show you later that are filled with organs versus the air in the lungs that's all black. So this image is actually an aortic dissection. You can see this line here. An aortic dissection is a tear in the large blood vessel that branches off from the heart. Symptoms for that can be sudden severe chest pain, back pain that radiates into the neck, shortness of breath, or loss of consciousness. Main causes for aortic dissection are chronic high blood pressure. Usually this occurs more in patients who are a little bit older, males that are about 60 to 70. Treatment can include surgery or sometimes medication like beta blockers. This is a pneumothorax. Do you guys remember what a pneumothorax is? It's a collapsed lung. So here on the right side of the patient, you can see that the lung is filling that entire thorax from front to back. But here, what happens is you've got the lung tissue here that's actually pulled away from the side of the thorax. So all of this right here is where the lung field should be, but it's pulled away and kind of almost like shriveled up. And again, here's another one. So normal right lung here, and then the left lung has pulled away and collapsed. So those are severely painful for the patient. I mean, it's really hard for them to get a breath. You know, it'll cause difficulty breathing, all that. This one, oh, I forgot, this one actually has a rib fracture too. You can kind of see right here. So this is probably what caused that pneumothorax. Patients can either have spontaneous pneumothorax, which there really isn't an underlying cause, it just happens all of a sudden, or it can be caused by an injury like a rib fracture, where it causes the lung to collapse. This patient has a scapula fracture, your shoulder blade. This is the left one here, so you can kind of see the fracture here and here. And again, this is a chest CT, we can tell because of the air-filled lungs and the vessels that are visualized. This patient has bronchial cancer, so you can see this mass here in the bronchioles in the lungs. This next slide kind of shows you the difference of how easy it is to see lung cancer on a CT versus a chest x-ray. So here's a normal chest x-ray. You've got the trachea here, right lung, left lung, and you can see the heart shadow here, diaphragm down here. This right here is cancer. There's a mass right here on the lung. So it's really hard to accurately diagnose that or determine that. So a lot of times what the radiologist would say was, you know, discrepancy in the upper left lung, recommend chest CT for verification. So once this is the same patient, once they have that chest CT, look at that cancer there and how clear you can visualize it and what the difference is between the x-ray and the CT. You're getting a much better quality image on the CT. But a lot of times we start with the x-ray because it's cheaper, faster, and easier. And a lot of times insurance won't allow you to have a CT if you haven't had the x-ray first. Depends on what it's for. This is a sternal fracture, most likely due to an MVA. So you can kind of see the difference here where it's fractured. A sternum is a very spongy bone, so you can kind of see here it's less dense in the middle. A lot of times in NVAs, patients that have their seatbelt on, they'll get a sternal fracture because it lies right under the seatbelt. So moving on to abdomen pelvis CTs. The prep for the abdomen pelvis is NPO for 8 hours prior. So we want to make sure that we're emptying out the bowel, okay? So we want to make sure that they don't have anything to eat or drink 8 hours prior. We do give the patients oral contrast for the abdomen pelvis. So what they're going to do is they're going to actually drink a quart of the oral contrast 2 hours prior to scanning. So they'll start drinking it over that period of 2 hours. The contrast is really going to help identify the GI tract, which includes the stomach, the small and large bowel. And it's also going to help detect abnormalities that are in these organs. Most abdominal scans will also include IV contrast, which helps enhance the vasculature. So vasculatures are the arrangement of blood vessels that are in the body or in an organ. So the perspective of a abdomen CT is not, they can really be easy, simple, there's no problem, or they can have severe issues with the patients. The oral contrast can make the patient very nauseated. So they might not be able to lay down, they might feel like they're going to throw up, they might be able to get sick, they might even vomit. It's just going to depend on the patient. Again, if a patient's having severe abdominal pain, it's going to be hard for them to lay on that table flat. And then it could also be painful from the needles. They're pretty routine. Again, they may have some emergencies from traumas, MVAs, things like that. There can be some pretty interesting things that you see. And again, there can be some difficult things that you can see. If you find out that something's going on with the patient that can be life-threatening, it's hard. You can be put at risk for things like HIV, AIDS, and hepatitis because of the needles. And if patients are vomiting and getting sick, then it can kind of be hard for some people to handle. You're going to have the same reactions to contrast that you would for any of the other exams. All the same side effects. The cost of the CT for an abdomen pelvis is going to be the exact same as a head or a chest, about $1,500, give or take. Again, here's some different scan planes. So you've got the axial scan planes, the coronal scan planes, and the sagittal. But again, the most common is going to be the axial scan. This is a normal CT abdomen. So again, you've got the spine back here, liver, spleen, pancreas. You can see some of the bowel here. The air is black, remember, so you can see some of the loops of the bowel and the stomach starting over here. This is a normal liver. Nice clear borders, a nice gray color. Everything looks fine. And then this one is cirrhosis of the liver. So you can see the normal tissue here of the liver, and then you've got all this darker tissue here. Cirrhosis is caused by scarring and inflammation. So you're kind of seeing that inflammation on the liver here in this scan. This patient has a liver laceration. So you can see here, there's that laceration in the fluid inside that liver where it's separated into two different portions. You can see the pancreas here, the spleen, the stomach, and then you've got your left kidney and your right kidney here. Here's the inferior vena cava and the spine here, and then where the spinal cord goes. This is liver metastasis, so this is where the cancer has metastasized to the liver, so you can see all these spots throughout here. And then again, you've got spleen, and then here's your stomach. This patient has kidney stones. You've got an axial slice and a coronal slice. You can see this little white spot in here is kidney stones. There's little ones right in here, and one right there you can see. This is a renal cyst or a kidney cyst. So here you've got your right kidney and your left kidney here. This is the healthy part, and then this right here is the cyst. on the kidney. Renal cysts are one of the most common abnormalities that are found on an abdomen CT. Most of them are benign and not much to worry about, but every once in a while it's concerning and they can be cancerous. Here is actually a renal carcinoma. So you've got normal kidney over here on the right, and then the left one, that mass has completely taken over the kidney and you can't even see clear definition of it anymore. Again, over here too. But this is cancerous. This patient has an abdominal aneurysm. So it's an enlargement of the aorta. So usually the aorta is pretty small. The aorta here is enlarged. And then you've also got this crescent-shaped thrombosis, which is a blood clot that's impeding the blood flow. Here's the patient's bladder, this whole thing right here. And then this portion right here is actually cancer on the bladder. This is a 10-year-old patient that has an IVC tumor. IVC stands for inferior vena cava. This patient is 10 years old and they have severe hypertension, which is high blood pressure. So their blood pressure is 210/160. So right here is the tumor, the IVC tumor. This is a 3-year-old patient that has a Wilms tumor. Wilms tumors are a very rare kidney cancer. They're actually highly treatable and they primarily only affect children. Okay, so you've got like a kidney right over here, and then you've got this huge tumor right here on the left kidney. Like I said, these are cancer, but they're highly treatable. This is a teratoma in the uterus. You can see this right here. We did talk about teratomas in one of the previous slides. So a teratoma is a tumor that's made up of tissues. They can be hair, muscle, bone. They occur a lot in women's ovaries. It's the most common place you'll find them. Can anybody tell me what's wrong with this image? So this is an abdomen image because you can see the liver here and the spleen here. What's wrong with this patient? Or stomach, I'm sorry, I said spleen. It's actually on the wrong side. So this patient has situs inversus where the anatomy is reversed and on the incorrect side. So some contraindications for different exams. For a head CT, the patient could not have an upper GI or a pelvic or OB ultrasound because we're giving them contrast, right? They could have the pelvic ultrasound before the head CT if they would forego the NPO. Because if we did a pelvis or OB ultrasound, they would be drinking water, which would violate the NPO prep. But sometimes they would still do it. Same with an upper GI. You couldn't have the upper GI and then have the head CT because it violated the NPO prep. Chest CT, same thing. Upper GI or pelvic ultrasound, we're violating that NPO prep. So we wouldn't want to have the scan afterwards. Some facilities might forego it, but if the patient has had anything to eat or drink in 3 to 6 hours prior to the injection of contrast, it can cause nausea and vomiting. A CT of the abdomen, the patient could not have an IVP, a BE, or a pelvic ultrasound. This one would violate the NPO prep. These two, there would be contrast in the abdominal cavity. So it would actually obscure some of the imaging that we're looking at. So we don't want that contrast in the large intestine or in the kidneys, ureter, and bladder while we're trying to look at the abdominal region on a CT scan. CT does have some limitations. Remember, I said that it's pretty much good at visualizing everything. The difference is there is some difficulty differentiating between bowel and gynecological tissue on CT. That is the biggest limitation. The other issues could be if the patient is pregnant. We don't want to scan a patient if they're pregnant unless it's a very high-risk situation where we do not have any other options. And also the limitation would be the size of the patient. Remember before, that hole the opening inside of a CT scanner is only so big. So if someone is very large or overweight, we might not be able to get them to fit through the opening. And also, our tables do have weight limits. So if the patient exceeds the weight limit, we're not going to be able to put them on the table either because it can damage our equipment. Who's performing a CT scan? It has to be a registered radiologic technologist. So you have to go through the radiology program and become a registered radiographer through the ARRT. So you would go through and then you would get your initials after you pass your board exam as RTR. Then what you would have to do is either train on the job if your facility would allow it, or you would have to do some additional training in CT and then pass the CT boards, which is still through the ART, and then your initials are going to be RTR for radiographer and then CT for computed tomography. So there is an additional training on top of becoming a radiographer. Career advancements are going to be the same as everything else. You can become a department manager, the lead tech, you can work in sales or applications, traveling around and teaching people how to use CT machines, or you can work in education. Compensation, again, is going to depend on where you live. Most of the time, it's about $29 an hour, and it goes up from there. You'll also get health, optical insurance, dental insurance, and a pension depending on where you work. Most of the time that's full-time benefits. Some places will offer part-time benefits to employees as well. There really are not any ethical issues because, again, the biggest ethical issue that comes in diagnostic imaging is unprofessional people performing the exams, unregistered individuals. With CT, they're done at hospitals. Not many places are going to have a CT scanner. So hospitals will require technologists to be registered within a certain amount of time. Most of the time after you finish your training, they'll give you 6 months to a year to pass your board exam. And if you don't pass your board exam within that time frame, they will let you go. I'm not going to do a separate slide for images because they were so integrated throughout the entire system, so I'm just going to carry on right here into some of the imaging. This is actually a CT fracture. So you've got your coronal and your sagittal planes here. You can see right here on C2, this is C1, your dens, and then this is your C2 vertebrae, your second cervical vertebrae. There's a fracture right here that's broken off between C2 and the dens. The dens is actually what holds your head on your spine with a bunch of ligaments attached to that, and you can kind of see the fracture here too. So that's pretty dangerous. A lot of times that's from an MVA situation trauma. This is what we call a burst fracture, or another name for it is a compression fracture. You can see it right here. So this is the normal size of the body of the vertebrae. This one here, it's actually smushed down. I know smushed is a very technical term, but it's smushed down and there's a fracture right through here. A lot of times that can be from a fall or an MVA causing that disc. What happens is the spine compresses down on each other and it causes it to break. This patient has a fracture and a dislocation of the pelvis. So here's your left hip. It actually came out of socket. Here's the acetabulum. It came out and there's a couple breaks here and here. You can see it. Very painful. This person actually had x-rays prior to the scan and the x-rays were negative, which means that the doctor did not find a break or a fracture. But once we did the CT scan, you can see here there's a fracture right through the acetabulum, here and here. So sometimes, like I said, that imaging is much better than plain x-ray films. This patient has a broken femur. You can see here, and you can see the nice little piece that's separated from it. This is a child with a goiter. This is a large growth. So here, if you can kind of get a good idea, here's the patient's eye, mouth, like chin area. Here's the neck, the spine. the back of the skull. This whole thing is a growth off of the front of the patient's chin and neck. This is an orbital fracture. So over here, this is nice and intact. So you've got the orbit here, you've got the black, which is the air in the sinuses. Right here, you can see the fracture. Hey! And then you can see how the fluid has actually filled the entire sinuses, other than this little area right here. This is actually a pregnant female that's scanned on a CT, so obviously you can see the entire sac here that the baby's in. Their skull, the head's down, ready to go. Humerus, Schultz scapula, some of their spine and their rib, femur bone, their little fingers here too. I don't exactly know what the reason for this scan was, but you can see here too how much effect it has on the internal organs and how, again, my technical term, they're smushed in different regions to make room for the baby. This is a rectal contrast scan, so you can see here the enema. We still use an enema tip. It's inserted. You've got the air and then the contrast that they use to check the rectum, see if there's anything going on, perforations. The future for CT is huge. There's a large growth in CT that's coming. One of the biggest is 3D reconstructions. So they can actually take a scan and they can make a 3D reconstruction of it, which is going to be very beneficial for things like surgery planning so that we can see what's going on. Even looking ahead to the future, think of things like if they're able to maybe 3D print organs from stem cells, they could actually take images from the patient, take a scan of their heart, for instance, and make a 3D replica of it. Then they could use that 3D imaging to reprint the perfect heart to fit that patient. Those are things that I'm hopeful for in the future. Another thing that they're using it for is forensic radiology, so doing virtual autopsies on patients, so they don't ever have to cut the patient open. This would be great for patients, especially ones that it's against their belief to have an autopsy done where they cut the body open. This is a virtual colonoscopy versus a traditional colonoscopy. So this one here on the left is a traditional colonoscopy where they put a scope in. They're looking through what they found here. This is a polyp, so they can see that polyp, visualize it. And then again, you can see it here on the virtual colonoscopy that's done with CT. These are some of the differences. So on a traditional colonoscopy, the gastroenterologist inserts a tube into the rectum, takes photos. They can see things that are going on inside of the colon like we just saw in the previous slide. But in this method of screening, if the surgeons find something like those polyps, they can actually take that polyp out and then they can do a biopsy and test it to see if it's cancerous. The problem with the virtual colonoscopy is they're less invasive, they're less expensive, so those are great options. It's going to take a picture inside the body just like a traditional colonoscopy would. The only difference is they cannot remove anything at that point. There's nothing that can be done. So the patient may actually have to follow schedule a follow-up procedure to go find polyps and cancers and then have them tested at that point. So if a patient's already had polyps before, or it's follow-up scans for cancer, they're not going to want to do a virtual colonoscopy. They're going to want to do the traditional one so that they can go in and do any testing that they need to do at that point. But it's still a nice option to have for individuals that have never had any issues, that they can go through and look at it. This is a 3D scan of a skull. This is a 3D scan of the posterior portion of the body, so you can kind of see the scapulas, the spinous process, the ribs, the back of the pelvis here. This is a 3D reconstruction of a skull fracture. So they can go through and they can see where the skull was fractured. These are great, again, for surgical planning, so that the doctor can go in and see how they want to plan to perform the surgery. 3D scans of an ankle and a knee. So here's the patella. There's a fracture here through the tibial plateau, and on the fibula here there's a fracture. So it's really good for orthopedic surgeons to go in and see exactly where the fracture is. They can rotate it around, look at everything, and they can again plan for surgery. This is an infant that has scoliosis. So these vertebrae should be sitting on top of each other just like this, but you can see here how they start to twist and turn out and curve. They can add color to this and do the reconstruction, so they can plan again exactly how they want to go in and have surgery. So this is a different patient that has scoliosis. So you've got your AP or your frontal view and then your side view, and you can kind of see how the twists and turns are. And then these are the x-rays afterwards, post-surgical. So once they've put the hardware in to kind of straighten that spine out. This is a 3D CT of the bronchi in the lungs. You can see all the branching of the different bronchioles. These are great for small cancers like bronchoalveolar carcinoma. They're really hard to pick up because it's very small little cancers inside of there. This is a CTA, computed tomography angiography. Remember, angiography is visualizing the blood vessels. So here we can see the kidneys, and we can see all the vessels that are branching off of there. This is huge to be able to see the arteries in there. This is CTA, angiography of the carotid arteries. So you've got your right carotid and then your left carotid. So this left carotid artery has stenosis or narrowing. See how it kind of indents here instead of having that continuous flow. Again, another 3D image. You can see the ribs, you can see the vessels, you can see the aorta coming all the way down, you can see the kidneys. It's really impressive to be able to see. This right down here is hard to tell, but this is an actual regular CT scan. And then again, the heart. So what they do is they just take the standard images and then they can do the reconstruction later and make the reconstruction into 3D, which is going to be highly beneficial for the future of diagnostic imaging. If you have any further questions about CT, obviously you can go to any of these websites. I actually have quite a few videos and images online. The thing that you can't really see on these still images is how you can scroll through a CT scan and see the image from start to finish. So if you have time, go through and look at some of those images on JetNet under optional activities. So that's it for CT.